with the little lady in PACU. We tried. But Matt was supposed to get intrathecal morphine and couldn't because she took Plavix.
No.
Okay, they're gonna consult.
Is your first abortion?
It was last week.
That was last
Yeah.
week.
Second month, so.
Well, would that be me or would that be?
Well, I think they're gonna just ask for help with their meds.
Oh, okay.
Yeah. That's what they're gonna
Yeah. AAA repair. It started leaking pretty bad.
Oh, really?
So she's like taken emergently to the IR suite.
Oh, nice.
Okay. Guess I'll do this one. Turned out fine. She like had a little bit of sedation and like didn't even go to sleep, but she did.
Was she an ER that like then was having leaking? Okay.
Bro.
Get your sphincter all tightened up.
Yeah. We're all shoved into like one corner of the room.
Totally.
It's tough to do a case up there.
Oh, where does it go back?
Yeah.
All right. Since there's not many of us, I think there might be 2 or 3 that will kind of trickle in here. I won't be keeping you the entire time. I have a meeting at 4 that I have to go to on the Prino. So the goal of these is these ITE reviews are just to talk about some things that I get feedback from the ABA about things that residents are missing. And this is not just our program, but nationwide. So we'll talk about some high points on the 2019 ITE or commonly missed topics. So organophosphate poisoning is something that is talked about every single test. You will see this on your exam. Maybe not the basic exam, but you'll see it on the ITE. You'll definitely see it on the advanced exam. You may see it on the basic, but it's something that they like to test every year. So what is it? You have insecticide poisoning or chemical warfare agents that go into the body, and these are rapidly absorbed through the skin, mucous membranes, or via inhalation. So you probably can really think back to what happened in London and probably a year ago now, where they had the presumed Russian involvement in putting this agent on a door handle. Somebody touches it. It really doesn't take very much to cause the issues of poisoning. So how does it work? You have inhibition of your acetylcholinesterases, and that's system-wide, right? It's your muscarinic synapses, it's your nicotinic synapses. And the key here is that it's irreversible. So the irreversibility is something that comes in usually later. Does anybody have an idea of hours or days that you need to have occupation of these agents on those enzymes for it to be an irreversible interaction? Is it fast? Is it short? Anybody want to throw out a guess?
It's a little while, I think.
It does take time. There's a process called aging of this interaction that has to take place, and some people think it's about 48 hours, about 2 days. So most people will present well before that, so you don't have to worry too much about that, but that's one thing you want to keep in mind is that you actually form covalent bonds after that 2-day period, and you're not going to separate those agents, and that enzyme won't ever be functional. Okay. The initial stimulation is excessive, as you might imagine. You're inhibiting that enzyme. You have acetylcholine that's flooding those synapses, can't be broken down. So at muscarinic and nicotinic locations, you have stimulation. But after a period of time, usually it's on the order of hours that then goes to more of the depression that takes place. What about signs and symptoms? So we talked about muscarinic and nicotinic pathways. If we're focusing on muscarinic pathways, what are going to be the signs for poisoning?
Excess salivation, diarrhea, maybe.
So what's in the mind?
Dumbbells.
It can be that one. A lot of people will still use sludge, right? Mm-hmm. Eat whatever you want to use, but the idea is that you have excess secretions really system-wide. So you get diaphoresis, you have increased secretions in the airways, increased motility of your GI system, so on and so forth. So those are the muscarinic effects. What about nicotinic effects? What do you see?
Probably like muscle.
Okay.
Like nicotine, I'm trying to remember it. So that's like more at the muscle level, and then like presynaptic.
Like spasm.
So The successive stimulation initially is spasms, fasciculations. You can kind of think of it as that initial succinylcholine dose that people will get. So that's what ends up happening early. What happens later then, after that initial phase? Weakness and paralysis. So that's what happens later, and that's what becomes deadly, in addition to some other pieces. So, again, fasciculations and then weakness and paralysis. So, what is the most common cause of death after nerve agent exposure?
Hypoxia?
From what?
I mean,
Diaphragmatic paralysis.
So it's hypoxia, but it's actually because of secretions in the bronchial tree. So respiratory failure is the far and away most common way people will die because they just can't get air down into the alveoli and gas exchange doesn't take place. So we'll get a little bit, hey, what's that? We'll get a little bit into the treatment here in just a moment, but the idea is you've got time to grab yourself something to drink and something to eat.
okay.
What's the other one?
It's the hospital ID.
Oh, the hospital
It
ID?
should be. So the treatment we'll get into in just a little bit, but pulmonary complications are what are going to be the leading cause. So let's get back into the treatment. Things that you're going to want to do, and actually the patients will do before they even get to see you, but removing their clothing, use soap and water to cleanse their skin. Again, this is going mucous membranes and through the skin. The water and soap can hydrolyze those agents, and so that's why it's an effective way to decontaminate. You want to have airway control and adequate oxygenation. That's first and foremost for those presenting to the ED, but then also when we are intervening. Cardiac monitoring. Why do we need to monitor the heart here? What could we see?
Bradycardia.
Yeah, so you can see the muscarinic effects of bradycardia. And so you can have profound sinus bradycardia, but you can also have heart block. You can have other manifestations as well. And the pharmacology here, atropine is going to be an agent that you would use, right? This is an anticholinergic. Prilidoxime is another agent that you would use, and pyridostigmine is another agent that you would use. So let's talk first about this question, and then we'll come back. So you have what drug is an appropriate medication for prophylaxis against possible nerve agent exposure?
I'm gonna say probably something stupid, but like rocuronium, something like that, that binds. Well, no, I guess something that would prevent acetylcholine from binding to muscles.
Good. So what? So not to muscles, but to the
Like
enzymes, right? So what could you give that is going to promote or prevent that interaction of your organophosphate and your acetylcholinesterase?
Neostigmine?
So those agents, your anticholinesterases, neostigmine, pyridostigmine, physostigmine, those are agents that you can certainly use. And if it was in our hands in the OR, IV agents is what we would use. But again, let's presume that this is a soldier out in the war area, and there's a risk for them to be exposed to chemical agents. They're not going to have IV agents that they're going to be taking. So what are they going to take to prophylax against symptoms if an exposure takes place? What's the difference between those three that I just told you? Neostigmine, pyridostigmine, and physostigmine, or physostigmine. Two of them are IV. One of them is oral. Which one is oral?
Not
Not
neostigmine.
neostigmine.
What do patients that have myasthenia gravis take?
The pyridostigmine.
Pyridostigmine. So that's the agent here. So on the test question, pyridostigmine is an agent for prophylaxis. If somebody's been exposed or they're showing signs of exposure, you don't want to use it. It's not going to do you any good. It's only to prevent symptoms if an exposure takes place. So it's prophylaxis only. And so soldiers use this. This is used a lot in the military. They take oral doses if they're going to be in areas that are high risk. Let's go back to atropine and pilodoxine. So what is this agent here, pilodoxine? What does that do?
Can I go back 1 second? Maybe I missed the beginning of this, but so we're talking about giving something like neostigmine for prophylaxis. Neostigmine is a cholinesterase inhibitor.
Correct.
It's going to increase the acetylcholine that's in the
It's
synapse.
preventing the interaction of that esterase, the acetylcholinesterase, with the organophosphate. So it's preventing this interaction. So you're inhibiting the enzyme because of your neostigmine, in your case, but it's covering up the binding site that the organophosphate could bind to.
Is the organophosphate a non-competitive or it's competitive?
It's a non-competitive.
Okay. So
it tends to be irreversible.
Okay.
Yeah. That's the key with it, is that it's an irreversible bond.
Okay. Got it.
So getting back to this agent here, what does that thing do?
I think that's actually what's responsible for like possibly cleaving the covalent bond that's formed between.
So yes is the kind of the short answer. The longer answer is that it doesn't cleave the bond per se, but it separates the organophosphate from the acetylcholinesterase. So it serves as a way to sterically inhibit that interaction. So again, if it's within that 2 days before that covalent bond forms and it's completely irreversible, pyridoxine can be put in to dissociate that interaction so that you get less of that muscarinic and nicotinic effect. And actually, let me backtrack, because that's one of the unique things about pyridoxine is that it does not have muscarinic impact. The unique thing about it is that it's only used for patients that are having weakness, and it only works at nicotinic motor end plate locations. So that's the limitation of it. Atropine, on the other hand, is the main agent for treatment in somebody that gets poisoning, and that agent, atropine dose that you're going to use is actually quite high. What kind of doses has anybody given atropine in the OR yet? Has anybody drawn it up? Okay. Most of the time when you draw it up, it comes in 0.2 milligram ampules. Sometimes it's a little more, sometimes it's a little less. You're giving 1 to 2 milligrams per kilo, oftentimes, in these situations. So the titration of your atropine is really based on the symptoms of the patient. And the symptoms are going to be respiratory symptoms. We talked about how your respiratory mechanics are going to be what kill people. And so what you're doing is you're titrating your atropine doses to decreased secretions as well as improved oxygenation. So you don't really care if they're tacking away at 140 because of the atropine dose that you're giving them. You're still titrating to whatever the respiratory status is. So atropine is what's going to save people from dying, and the pyridoxine is going to help keep them from getting paralyzed. Any questions about those things?
Has anyone seen the movie The Rock?
Oh yeah.
You know the last scene, Nicolas Cage, when he's like trying to stop the bomb. Anyway, he has organophosphate poisoning from the VX gas. And he puts atropine in his heart.
Oh yeah.
When he's got the flares.
Yeah.
You'll never forget.
That's perfect.
Dude, I totally forgot these stabs himself in the heart.
I remember that part.
Stabs in his heart.
All right.
Any questions about those drugs? That shows up on time and time again on the test.
Does atropine like plateau in how much it'll increase your heart rate?
It does.
Okay.
Yeah, it's not going to be.
It's not just going to make it explode.
No.
Okay.
But that's the thing that a lot of people worry about. They say, you could be asked a question that you're titrating to heart rate, but that's not the case here. Heart rate you don't care about at all. Unless, of course, they're going into ACS, and then that's a whole other issue that you've got. The patient exposed to a chemical nerve agent presents to the ED and requires emergent intubation. What neuromuscular blocker must be avoided? You got limited options.
Yeah.
Start throwing something out.
Sucks.
So sucks is the right answer here. Why succinylcholine?
Because you'd just be making the problem worse.
You do, and on top of that, think about how your organophosphate poisoning is impacting the neuromuscular junction. You don't have any other way to metabolize your acetylcholine out, right, so that it doesn't keep working. So its duration of action itself is going to last a whole lot longer because you don't have things at the neuromuscular junction to break it down. So succinylcholine not to be used here. So if you want to do an RSI, you'll do so with rocuronium or maybe nothing, depending on how bad the patient's doing. Any other questions on organophosphate poisoning?
So if it's an irreversible bond between your acetylcholinesterase and your organophosphate, don't you make more acetylcholinesterase eventually that's not bound? So it's not paralysis for life, it's just paralysis until...
Well, people will die from the respiratory complications first.
Okay, but if you like keep them intubated, keep them on a bed, and can deal with the acute stuff, they will eventually...
Yes.
Okay.
That's correct. And I think that's what happened in that case in England where the person got exposed, ended up living, but was, sounds like, intubated for quite some time because of paralysis, because of weakness.
Yeah.
Acute cocaine intoxication. So 90% protein bound. Its half-life is relatively short, 30 minutes to 90 minutes. You have hydrolysis and ester cleavage, mostly. That accounts for 90 or 95% of its metabolism. And then you have a little bit that goes through the liver for metabolism. Working back a little bit, which class of local anesthetics does cocaine belong to? There's two classes. Which class?
Stimulants.
Esters, right? So it's the ester class. That's why you have an ester cleavage. So those esterases are going to be acetylcholinesterases that are found in the blood and the serum. Same ones that metabolize your REMI, same ones that metabolize SUX when you inject it. So the vast majority of your metabolites are going to be from those two entities. The interesting thing about your metabolism is that this creates a metabolite that has a lot of the effects that we expect to see from cocaine. Vasoconstriction and increased sympathetic tone. This one, on the other hand, is almost the yin of the yang. So it actually causes some vasodilation, and it's thought that this component here is what allows people to have a broader range of therapeutic window, if you will, before they can kill themselves. This is a protective metabolite from this. Does anybody know when it comes to, actually I'm not going to talk about this yet because I think I have a question here in a little bit about drug testing. These metabolites made here are renally excreted. The effects of cocaine, there's really three things that you can think about. The reuptake of catecholamines, so a lot of people think that that's why they get the euphoria. That's where the addiction comes from. So you have kind of the serotonin pathway that they believe is where that euphoria comes from, and the dopamine pathway where the addiction comes from. But it's reuptake blocking that takes place there. From the local anesthetic standpoint, you have sodium channel blockade, and so we'll talk a little bit about what you might think about for cardiac effects with cocaine intoxication a little bit. And then you have glutamate secretion, so this is just global activation of the CNS, and that's the stimulant component. All right. So clinical manifestations. Dose-dependent increase in heart rate and BP. So the more they take, the higher their heart rate goes, higher their BP is. You can get cardiac ischemia because of this increase in heart rate and blood pressure. Interestingly, the blood pressure piece is tied to alpha activation in the periphery, so your SVR goes up. But your coronary vasculature also has increased resistance. So that's part of the reason why they're getting cardiac ischemia. Not only they're having increased heart rate, so the oxygen demand is high, but the blood flow into the heart is restricted because of this constriction of the coronary vessels. Dysrhythmias, as you might imagine, tachycardia of various types. You can have SVT, you can have other types of ectopy that are showing up. So dysrhythmias are pretty common, especially for higher doses. Thrombus formation is something people don't think about, but that's something in the acute phase you could be worried about. So there are higher chances of throwing clots, and typically these are going to be arterial clots usually. For CNS issues, seizures can present, and from the high blood pressure, you can have an intracranial hemorrhage. So those are the neurologic manifestations of over-intoxication. And the last thing that comes up is hyperthermia. And this is thought to be due to this intense vasoconstriction happening peripherally. So they can't control their core body temperature because they can't vasodilate to have heat dissipation through their extremities. And so they get to be hyperthermic. And if your patient is hyperthermic because of cocaine administration, they actually have a pretty high mortality rate. So a quarter or a third of them, if they're profoundly hyperthermic, are going to die. So that's a late sign, severe sign for those patients. So what about chronic use? Chronic use, really you're just going to see one manifestation that comes up time and time again. This shows up on exams once in a while. Cardiomyopathy, and it's of the dilated type. So these patients will come in with non-ischemic cardiomyopathies that have a dilated ventricle, and they have issues related to that. So here's the question. A patient presents to the ED, status post vehicle crash, and requires multiple orthopedic interventions. A UA that was taken shows positive screen for cocaine. Is the patient acutely intoxicated with cocaine? Who says yes? Who says no? So for those of you that say no, why do you say no?
Seems like a trick question.
I don't trick people.
I don't know how long it takes till it gets into the urine, but doesn't it stay for like 2 to 3 days?
So that's the point here that we're getting at. So the UA for these, for particularly cocaine, is actually not measuring cocaine. So as we saw earlier, the half-life is how long for cocaine? 30 to 90 minutes. It's short. So if it was measuring cocaine, the molecule itself, you would have a very small window to show a positive screen. So the actual agent that it's looking at is one of those metabolites that I mentioned earlier. It's the one that is achieved through the hydrolysis. I forget what it's called, but it's BE is the shorthand notation of it. That is an agent that stays around for days. So as you said, a couple of days usually is a window if somebody's intermittently using it. But if somebody's chronically using it on a consistent basis, you can have a positive test upwards of 10 days, or we're going to have. So just because this person has a positive screen doesn't necessarily mean that he is acutely intoxicated at this time. And this is a great example of why that becomes really complex. You see this at Denver Health sometimes. They have to go to the OR. Or are they in an acute phase of cocaine intoxication or not? And so that can impact your anesthetic and how you're doing them. Things that you might look for in terms of agitation, tachycardia, hypertension could all be complicated because he's in a lot of pain. A lot of things could be going on that cloud the picture. All right, so kind of a similar situation. Same patient. The UA shows positive screen. You presume that the patient is acutely intoxicated with cocaine right now. What medication will you give to counteract the acute cocaine effects?
Alpha blocker.
What did you say?
Alpha blocker? Beta blocker?
So we'll talk about alpha blockers and beta blockers in just a second. Neither one of those is the right answer.
Nitroglycerin.
So nitroglycerin is not the right answer here either. However, we'll talk about that one as well. It's something that we give all of the time. Benzodiazepines. Right, so benzodiazepines for an acutely intoxicated cocaine patient, you want to use benzodiazepines, and what you're doing is you're counteracting that activation both centrally as well as peripherally. So it can require high-dose benzo administration to kind of get people down. So that's actually the first agent you're going to go for to try to get heart rate down, blood pressure down. That's the agent that you want to use. And so, again, that's going to be the first line therapy. So, patient with acute cocaine intoxication is persistently hypertensive. What drug should be avoided to treat the hypertension?
That was alpha blocker. Because then you get all the catecholamines and they're going to increase the heart rate.
You avoid the non-selective beta blockers.
So, in general, you avoid beta blockers.
Okay, yeah.
Beta blockers, both of specific selective type as well as the non-selective type, is what you want to avoid. What's that, Marcus?
So you couldn't do like labetalol?
What's that?
You wouldn't want to do even labetalol?
Labetalol has been used. There's case reports that have been used. There are probably people more on the anesthesia side that deal with this that say it's probably fine. But the hardcore people that see this on the floor in the ED would go to things like nitroglycerin, nitroprusside, nicardipine, other quick titratable IV agents to get blood pressure under control. So the idea in this situation is that this unopposed alpha activity is what you're trying to avoid, and that's the idea behind not giving a beta blocker or something that has mixed activity, because you can worsen this alpha activity. Does that make sense? So in the OR, we don't see this a ton because we give agents that are going to depress cardiac function, decrease SVR, so most people are going to have their blood pressure come down into a range that's reasonable. But if it's a relatively short case, you go to PACU, all of your medicine's gone, and all of a sudden they're hypertensive again. This is what you might have to consider, is putting them on some IV agent to keep their blood pressure under control. Because they can go into a hypertensive emergency very easily and have renal as well as issues related to blood pressure pretty easily. Any other questions on acute cocaine
Toxicity.
Intoxication. Anybody else with ideas on that? The other thing that comes up, Marcus, you may have seen this. What is the relationship with epinephrine in acute cocaine toxicity?
Relationship with epi?
Yeah, so the fact that a patient and they're acutely intoxicated on cocaine, is that a patient that you want to give epinephrine to for either profound hypertension? Or
Potentially you're precipitating, you've blocked reuptake, and so you're going to have a profound response to it.
Yeah, so they can have an exaggerated response. So anytime you're dealing with epinephrine and somebody's acutely intoxicated with cocaine, you want to really think about the doses if you have to use it. If you have to use it, you have to use it, but you got to remember that they may have a very disproportionate response to a dose that you might give 10 mics and expect a small change, and all of a sudden you get this profound change. Have you seen any other questions on cocaine intoxication?
I don't think so.